A very good afternoon to all of you, and I thank Dr. Kumudini Madam to give me this stage to talk to you. So I'll be talking on isolated cranial nerve palsy. What's next? Is it a benign or a malignant thing, and should we be concerned about it? Because what others do we only take up as ophthalmologists these cases, or we should have a collaboration with other physicians and neurologists? How do they present to us? I have no financial interest in this presentation. An isolated cranial nerve palsy presents a multifaceted challenge in both diagnosis and treatment. As we know, the etiology of an isolated third nerve palsy, just I'll be focusing on one, is diverse and can range from benign to life-threatening. And the key considerations, which is very important, we look at the pupillary involvement. We always ask for a history of microvascular or a trauma. And there are always mimickers, and we should keep it in mind, be internuclear ophthalmoplegia, myasthenia, or a thyroid eye disease also. And to avoid misdiagnosis, a thorough understanding of its anatomy and symptoms and etiology of the cranial nerve is quite essential. So we give you certain case-based, and let's understand what it is. A 60-year-old female who presented with double vision since 2 days. So it was quite sudden, but when we asked her, she was not very clear actually what it was, and after it was followed within 2 to 3 days, followed by drooping of the right eyelids. With this history, when we asked her the detailed history of anything in the past of fever, illness, or anything she was suffering of, she said she has nothing of that sort. Looking at her medical records, it was all normal. Neither she was a hypertensive, neither a diabetic. Looking at the ocular examination, her visual acuity was 6/36 in the right eye, and the pupils were normal size and reacting to the light, and she had a nuclear sclerosis of grade 2 in that eye. In the left eye, she had a cataract surgery with a PCIOL in position and has a 6/9 vision in that eye. This is the 9-gaze photograph, and you can see that there was a complete ptosis in this eye, and she had a adduction restriction in that eye, and it was clearly pointing out to a case of a isolated third nerve palsy without the pupil being affected. So when we see that the pupil is not affected, we are a little bit relaxed enough and thought that it can be maybe something to do with a intracranial tumor which may be affected, as she was an elderly lady. Fundus was actually normal, but when we examined her, this is what we saw. There was a swelling in the medial end of the right clavicle near the sternocleidomastoid joint, which was 5 × 4 centimeter, bony, hard, and tender. Chest X-ray, we are advised for a chest X-ray, and we could see a expansile osteolytic lesion in the medial 1/3 of the right clavicle, along with a pathological fracture. So when we also asked her, did you have any back pain? Did you have any pain in the she said yes, it was there sometimes, as they say always. So we took the help, when we ordered for a routine checkup of blood investigations. When it came out to be normal, we took the help of our physicians, and they actually said what we got was the ESR, which was high, and the serum viscosity was high. So they asked for the other things, keeping something in mind, and that is what came out to be immunoglobulin A and G with the M spike, and the urine analysis showed a Ben-Jones protein. What we also did was the FNSC from that mass, and then it collaborated to that. There was a plasma cell with eccentric nuclei, which was suggestive of low-grade multiple myeloma. Since the MRI brain and orbit, which she was already carrying because she had gone to multiple to one of the ophthalmologists before she came, which was normal, she was advised for this T99 phase 3 bone scan, and that also showed a low-grade malignant process involving the medial part of the right clavicle. So she was started on chemotherapy with CD regimen, cyclophosphamide 400 mg for weekly, thalidomide 50 mg daily for 2 weeks, followed by 100 mg daily for the next course of 4 weeks, and dexamethasone 200 mg daily once a week. And after 4 weeks, when we saw, there was a resolution of the third nerve palsy. So what we say in multiple myeloma is a neoplastic proliferation of the malignant plasma cells that secrete monoclonal proteins, the what we have to say, they usually present with the bone pain, and they can have a fatigue, they can have a weight loss, and they can have a anemia also. But our patient did not give any of this. So why did she have an isolated cranial nerve as the first symptom which was presenting? It can be because of the hematological process, which was a hyperviscosity in our case, which we saw. It can be because of microvascular effect, or it can be because of a direct compressive effect of the basal cell or cavernous sinus or the orbital apex by the intracranial plasmacytoma. So literature review said that the first case was reported by Sundaran et al. And then Kashyap et al. Also saw two patients in which they saw that during the course of chemotherapy, one of them developed abducens palsy, and the other was presenting with third nerve, which later had a basal cell plasmacytoma. So you can see third nerve palsy even after resection of this tumor masses, and so they can have a varied things when they will be presenting. So managing a third nerve palsy, it requires addressing the etiology. So just not looking and saying that it's isolated and can be hypertension or a diabetes. So keeping the mind of vascular risk factors, neuroimaging and lab tests are crucial in evaluating any isolated cranial nerve palsy. I come to the second case. This was a 56-year-old male who presented with left-sided headache for 3 months, pain and drooping of the left eye for 10 days with a normal medical history, and the anterior segment was normal, but the pupil was mid-dilated and was sluggish, reacting to the light. So this is the picture, fundus picture, which we are seeing, where you can see the left fundus is having a disc pallor in these cases, but the lower rim was literally normal. This is the OCT picture of the patient, which is showing thinning of the RNFL of the superior nasal and temporal quadrants of the left optic disc. So this is what was showing the field defects, and he was diagnosed as a non-arthritic AION, but a diagnosis of a painful like a pupil affecting the third nerve, which was made, and he was asked for a CT angio in this case to rule out any posterior communicating aneurysm, but MRI brain and orbit showed that there was an enhancement in this area of the superior orbital fissure and optic nerve canal and the orbital apex. So since we had also this patient had other symptoms slowly developing, and we had to take the help of our respiratory physicians into the play, and she was asked for a PET scan because we could not go deep and take any any tissue from that area. So it was performed after 6 weeks of the initial presentation, and there was a hilar lymphadenopathy, and then he has to undergo a endobrachial guided needle aspiration, which showed a non-granulomatous lesion, which was suspected to be of sarcoidosis. All the blood investigations were normal in that case, so a diagnosis with a neurologist was a sarcoidosis, and started on treatment. I'm not going about the treatment part. What I wanted to emphasize here is painful pupil involving third nerve palsy is commonly due to posterior communicating artery aneurysms, and however other compressive lesions must be ruled out when CT angiogram is normal. Always think of a compressive lesion involving the superior orbital fissure in any patient presenting with both third nerve palsy and optic neuropathy. And there are modern imaging you can take help of, and diagnosing a neurosarcoidosis is not always easy, but it can help us out. So this is my last case. This is a 30-year-old female who presented with fever, headache, sudden onset of drooping of the right lid for 5 days, and there was a restriction of adduction in these cases with exotropia, and there was a total third nerve palsy, but the pupil was normal and reacting. Her all blood investigations was normal, and slowly on the process she developed neck rigidity, and LP was done in these cases. Proteins and cells were raised, and other parameters was almost normal. She was asked for a neuroimaging, and this is what we are seeing in the neuroimaging. In this, we don't see anything caseating in this, but this is what was the reason. So what I was trying to say, there was a basal exudates in that, and she was diagnosed as a case of a TB meningitis and started her treatment, ATT treatment, and slowly her third nerve palsy resolved. So TB meningitis presenting as a febrile illness with features of meningeal irritation and a previously unreported finding of complete ocular nerve palsy due to this basal exudates is quite rare, because most of the cases are usually presenting as tuberculoma in the brainstem. So these are certain things also we have to keep in mind when we see different manifestations of a isolated third nerve palsy. So my take home message is cranial nerve palsy can be the first manifestation of systemic illness. Painful people involving third nerve is an emergency, as aneurysm is the most common cause. But we have to also think of neurosarcoidosis, which can be kept, and certain vasculitis, other things should be kept in mind. And TB meningitis should be suspected in all patients having cranial nerve palsies in the setting of meningitis like illness. And neuroimaging is a must in painful, progressive, sudden onset palsies, and also in young patients, to help for saving the life as well as sight. Thank you.